So today's topic, I always kind of like to mix it up a little bit. I think that last time I was here, we talked about congestive heart failure. We talked about, stress testing. But today I wanted to do two things. I wanted to spend the first half of the lecture talking about integrated rheumatology. And why do I call it integrated? Is because the theme is rheumatology is not just a disease of the joints. It affects almost every organ in the body. Of course, thinking about diseases like rheumatoid arthritis, like a lupus. And I really wanted to show how a rheumatological disease can affect the lungs or the heart. You never know. So integrated rheumatology. And I really wanted to spend a lot of time talking about some of these biologics and drugs that can get very confusing for the boards. And then another topic I feel goes under the radar, but I've been seeing a lot of questions about that throughout the years is the adrenal gland, and I wanted to focus about primary adrenal insufficiency and really focus not only about, how do we diagnose it, but also how do we treat it. So those are going to be the two things that we're going to be talking about today. So when we talk about integrated rheumatology, for those who know me, I always love starting off with a question. It's going to be the best. So let's talk about this 56-year-old woman is evaluated during a follow-up visit for persistent rheumatoid arthritis, persistent RA. She was diagnosed with this condition about a year ago. She began treatment with methotrexate. She takes 20 milligrams weekly. It's an appropriate dose. Hydroxychloroquine, 400 milligrams a day, which is also appropriate. And something called etanercept, which is the TNF inhibitor that was added about 6 months ago. For the past 2 months, she has had persistent pain and swelling in the hands and the knees, as well as increased morning stiffness that lasts up to 3 hours. Of course, for those of you taking your boards, one of the buzzwords that help determine if it's inflammatory versus non-inflammatory joint disease is the terminology morning stiffness, of course. And 3 hours is quite a bit of time. These symptoms interfere with activities of daily living. She's on prednisone 5 milligrams daily, and this was added around 4 weeks ago and has only provided modest benefit. Her medical history is significant for osteopenia, and I'm sure being on 5 of prednisone is not helping that. She also takes alendronate, which is a bisphosphonate, probably because she has a high risk of developing osteoporosis and she has osteopenia. And she takes some calcium and vitamin D as well as folic acid because she's on methotrexate. On exam, vital signs are normal. Range of motion of the shoulders is decreased, and there are nodules on the elbows bilaterally, and bilateral synovitis of the wrists are noted. So nodules on the elbows are very common when we talk about people with rheumatoid arthritis, these rheumatoid nodules. There's bilateral swelling of the wrist, and the key thing is it's bilateral. So of course, when we talk about symmetrical arthritis really implies an inflammatory type arthritis. And of course, we know this patient has RA. Grip strength is decreased. There are small effusions on the knees, and there's some squeezed tenderness of the metatarsal phalangeal joints bilaterally. So that just means you hold your hands out and you squeeze it, and ooh, that hurts. They get some labs, and her hemoglobin's 11, so it's low, probably having some anemia of chronic disease. Her leukocyte count is 8,000, ESR is elevated. Her rheumatoid factor is positive, and her anti-CCP antibody is also positive. And of course, when we talk about the classic combination to help diagnose RA with the history and physical, of course, we think about rheumatoid factor positive. Rheumatoid factor is an IgM antibody, and anti-CCP is also a more specific antibody for RA. And the combination of rheumatoid factor being positive and anti-CCP really, not only would I say it's the peanut butter jelly of making the diagnosis as far as serology, but they probably have a really tough course. And it sounds like this patient's having a really tough course. They do radiographs of her hands, and it shows erosions. So it's a very aggressive disease, why it sounds like they're treating this patient with a biologic. Of the right second metacarpal phalangeal joint and at the base of the left fifth metacarpal bone. And unfortunately, diffuse periarticular osteopenia is also visible. We knew this patient also had osteopenia and is probably at a very high risk of having osteoporosis. Um, which of the following is the most appropriate next step in this patient's management? So, of course, in the perfect world, I'll make you raise your hand. I'll make you I'll call on you, or do an audience poll. But let's just walk it through this together. So, is the right answer going to be A, add infliximab; B, discontinue etanercept, switch to infliximab; C, discontinue methotrexate, switch to sulfasalazine; or increase to prednisone? So this is once again is someone who has rheumatoid arthritis, is on methotrexate, hydroxychloroquine, and a TNF inhibitor, and is doing worse, and was added prednisone at that time to kind of help out, and only had modest benefits. So which one would I kind of knock off right off the bat? My default for knocking off has to be D, add prednisone. So on the boards, anytime it says just crank up the steroids, chances are that's going to be the wrong answer. Steroids, they have some benefit, but they have a really long list of side effects. And of course, in this vignette, this patient already has osteopenia. This is not someone you want to keep on cranking up the prednisone. And we'll talk more about it. So really, anytime it says give more prednisone, chances are that's not going to be the right answer, okay? So D is going to be the wrong one. What about A? How about adding a TNF inhibitor to already having a TNF inhibitor? So, of course, anytime you talk about giving double biologics, especially in this case, TNF and TNF, that just sounds like the wrong answer. And in general, we don't give a biologic and what we call a small molecule together. This is going to be too much immunosuppression. And we'll talk about that in a second. So it leads you to B and C. So I would probably knock off C, discontinuing the methotrexate and just switching it to sulfasalazine in someone with this being very symptomatic is going to be the wrong answer. It's not going to help out. There is something where it was, continue methotrexate and then maybe continue the hydroxychloroquine and add the sulfasalazine. Well, that's something called triple drug therapy. It may be an option. Triple drug therapy went head to head with being on a TNF inhibitor. And, it's cheaper and it has just as good, I would say efficacy as a TNF inhibitor. But this patient's already on a TNF inhibitor and, not doing poorly. So, just making this one-dimensional switch as in choice C is just not going to help the patient out. So if you didn't know which one to pick, I think your default answer is going to be B as in boy, but that made sense. Discontinue the current biologic TNF inhibitor and switch to another TNF inhibitor. And what's the take-home message there is that when we talk about biologics, TNF inhibitors in particular, that when you fail one, that one's not working for you, well, you could try another medication in the same class. And we'll even dive deeper in 1 second. So, if you want to try infliximab, if you want to try adalimumab, they all have similar efficacies. So just because you fail one doesn't mean you fail them all. And that seems like the right answer there. And I did mention about triple drug therapy. I put a couple of quick articles about that. Now, to be very specific, in general, not in this specific case, is that triple drug therapy is methotrexate. Triple drug therapy includes hydroxychloroquine and sulfasalazine, and it was non-inferior to a TNF inhibitor. In this case, the one they used was etanercept. And of course, you think about this, a lot of it's going to be cost effectiveness. That triple drug therapy is going to be a lot cheaper than putting someone on a biologic. So if you give both choices on the board exams, I definitely would think about triple drug therapy as long as there's no side effects that you have to worry about, because it's just so much more cost effective than being on a TNF inhibitor. But for this question, let's not get confused with what is the take-home message? That just because you failed one TNF inhibitor doesn't mean you failed the whole class. And that's why you could try one. In this case, it was etanercept, brand name Enbrel, and they wanted to try generic name infliximab, brand name Remicade. So yes, I made this chart, and I put this here because what did I want to spend some time with in this case is all these different medications for rheumatology. And I'll try to go as slowly as I can. I know we only have an hour together, but the way I look at medications for rheumatology is that I break them up, number one, into anti-inflammatory and DMARDs. So when I think of anti-inflammatory, three broad categories jump to mind. non-steroidals, COX-2 inhibitors, and glucocorticoids. One thing that all three have in common right here, they're all rapid acting. When do we think about non-steroidals and COX-2 inhibitors? When it's very, more like an arthralgia per se, not really arthritis. And if it's arthritis, it's something that doesn't have erosions. It's not really affecting their quality of life. It could be giving some aches and pains. You could think about non-steroidals. The two organs you always have to worry about is going to be number one, the kidney. Non-steroidals can cause, an interstitial nephritis. When we talk about non-steroidals, they affect the afferent arteriole, could give you kind of like a pre-renal type picture. So you always want to watch the kidneys. You also want to worry about the GI tract, right? You worry about things like peptic ulcer disease that can lead to bleeding. So those are the two things I worry about with non-steroidals. When should you use a COX-2 inhibitor clinically or on the boards is when they state in the vignette needs to be on a non-steroidal, but you really worry about the GI side effects of peptic ulcer disease. Just because you're on a COX-2 inhibitor doesn't guarantee you that you're not going to get a peptic ulcer disease, in the right setting. If someone has a history of really bad ulcers with bleeding in the past, you may consider putting them on a PPI with the COX-2. But remember, COX-2 can definitely still affect the kidney. The claim to fame for COX-2 inhibitors is that it's not as toxic when we talk about the GI tract. Now, glucocorticoids also rapid acting. They do have benefit. And of course, the minute you start one, you want to taper them off as quickly as possible. When I talk about side effects of glucocorticoids, well, there's just not enough room in this whole PowerPoint to talk about side effects. But needless to say, of course, there's weight gain. There's going to be easy bruising of the skin. You could definitely have hypertension, diabetes, osteoporosis, just like in this patient over here. In the eye, you worry about cataracts, glaucoma, just swelling in general. So, of course, steroids, though you need it sometimes to bridge other types of DMARDs to kick in, you always worry about those side effects. So those are anti-inflammatories. When I think about DMARDs, I put DMARDs, disease-modifying anti-rheumatic drugs, into three broad categories. I put them into non-biologic, I put them into what they call small molecules, or biological DMARDs. So when we think about the non-biologics, they've been around for quite some time. And what do I know for the board exams is definitely going to be what are their side effects, So the most important non-biologic to think about for your boards, and someone especially with rheumatoid arthritis, is methotrexate, right? How does methotrexate work? It's a dihydrofolate reductase inhibitor, which is why when you give methotrexate, you want to give things like folic acid daily, or maybe in other cases, people use things like leucovorin. They could give that weekly, but folic acid daily, 1 milligram, sounds good to me. Methotrexate is a weekly, meaning once a week dosing drug, which is nice for compliance. It comes in 2.5 milligram doses or 7.5 milligram doses. And for rheumatoid arthritis, we use around 20 to 25 milligrams weekly, which is nice. Side effects, I don't know where to begin. Clinically, you want to start low and titrate up because of the fact that you get a lot of GI side effects. Before you start almost any of these drugs, including methotrexate, you want to rule out hepatitis B and hepatitis C, especially because the medication can be irritating to the liver. When you're on the medication, you want to check your LFTs, really focusing on the transaminases, AST and ALT when you're on methotrexate. You definitely want to check a CBC also every 4 months because you could get some cytopenias from that. It's inhibiting folic acid. You want to be careful of the drug when you have chronic renal insufficiency or chronic kidney disease. So it's something that people forget. You don't want to be on the drug if you have a very low estimated GFR in these cases. Routes, we usually give the medication orally. It can be given sub-Q and IM, mostly sub-Q, but I'll tell you one thing from a clinical perspective, it's hard to get approval for those drugs or even auto-injectors, and those are really hard to get approval for. But why would I give it, injectable-wise is because of the fact that they're having a lot of GI side effects. You probably get better bioavailability with it. So definitely think the cornerstone non-biological DMARD is definitely going to be methotrexate, and many studies will add on to methotrexate. The drug right below it is called leflutamide. It's kind of like the brother of methotrexate. Methotrexate is a purine inhibitor, while leflutamide is a pyrimidine inhibitor. And in rheumatoid arthritis, rheumatology, they use combinations of methotrexate, sometimes with leflunomide. But for your boards, when you pick it, if they need to be on methotrexate, but they're having side effects, such as maybe they're getting some lung toxicities. Truth be told, I don't see a lot of lung toxicity with methotrexate, though we all memorize it, but if they're having some kind of suspected lung toxicity, this will be a time to consider a drug like leflunomide. It is given daily. You do have to check your liver enzymes when you're on leflunomide. Azathioprine is also a very commonly used drug in rheumatology, not specifically rheumatoid arthritis. It's definitely dosed based upon weight. You want to worry for GI side effects. You want to make sure that they don't have bad cytopenias. You may want to check a CBC during therapy with the medication. Mycophenolate, everyone knows that as the brand name Cellcept. Usually for most rheumatological diseases, I'll probably be on the higher dosing of like 3 grams daily in divided doses. You definitely worry about GI side effects. You do want to check a CBC on it. Hydroxychloroquine, very weak anti-inflammatory. I think more about hydroxychloroquine probably in a lupus patient more than anything else. We all memorize the retinal toxicity that's non-reversible. Get a baseline eye examination when you're on hydroxychloroquine. Classic thing is to consider checking a G6PD level. These people who are susceptible could definitely get some kind of anemia when they're on this medication. Sulfasalazine, kind of part of that, what's it called? They call that triple drug therapy, but careful in sulfa-allergic patients. Not a very potent anti-inflammatory. Cyclophosphamide, definitely has its toxicities. It can be given initially through IV, then switched to oral. I think most of us memorize the hemorrhagic cystitis when they're on this medication. That's why we give a medication called Mesna when you're taking cyclophosphamide. It really does suppress your immune system. It's pretty rapid acting compared to a lot of these other ones. Methotrexate, as well as these other medications, takes a while to kick in. I think for your boards, you should know it takes at least 6 to 8 weeks for methotrexate to really kind of build up there, which is why we sometimes bridge with things like steroids, but we can't wait to take them off. So when you talk about the non-biologics, just feel free to, we add at least 3 of them sometimes. That's triple drug therapy to help out patients. But, if they're not doing well, you could consider adding a biologic or a small molecule. Let me kind of jump into biological DMARDs now. So biological DMARDs actually have 6 categories, and I'm sure down the line there'll be 7 and 8. These are such popular categories. And the 6 categories of biological DMARDs include TNF inhibitors, T-cell inhibitors, B-cell inhibitors, a bunch of interleukin inhibitors, and of course this list right here is not complete. Interferon inhibitors, and of course, what list is not complete without the word other? You know what I mean? So biologics really suppress your immune system. With no matter which biologic you're going to be using here, you probably want to rule out latent TB, and that's when you're probably going to do whether it's going to be a IGRA, interferon gamma release assay, such as a quantiferon gold, or in some cases something very traditional like a PPD. You also want to rule out Hep B and Hep C in these patients, but you could consider TNF inhibitors. And I put a bunch of them down here. The 3 classic ones are infliximab, given through the IV. Then, of course, there is adalimumab, which is Humira, and etanercept, which is Enbrel. And there's some other ones out there too. You want to be careful giving TNF inhibitors in patients with demyelinating disorders like multiple sclerosis. You do not want to give these medications to them, so please be careful. And if you don't do well on one, you could try another. It's not a class effect. T-cell inhibitors, the one out there is called abatacept. It goes by the brand name Orencia. And on the boards, you may want to consider something like abatacept if they failed a majority of these TNF inhibitors, or if there's a contraindication to use a TNF inhibitor. Classic example would be someone with a demyelinating disease. Now, if it's not the T-cell inhibitor, it's going to be a B-cell inhibitor. B cells definitely make antibodies. B cells turn into plasma cells to make antibodies. So it kind of makes conceptual sense why we want to use them. Medications out there, the classic one is rituximab. Another one that's used specifically for SLE is belimumab. And please forgive me if I pronounce anything wrong. They're not easy. This is a medication goes by the brand name Benlysta, which is not used for lupus nephritis, but used for bad arthritis and skin disease. And that was a downside. We don't use it for lupus nephritis. It's a downside. We don't use it for CNS lupus. But that's really why, not to go out of order, these interferon inhibitors kicked in. One of them is called anifrolumab, which got the FDA approval for lupus, specifically lupus nephritis. So now lupus has two biologics you can use. One is a B-cell inhibitor and one is an interferon inhibitor. And of course, you really want to do a deeper dive into lupus to get more indications when you use these medications. Back to biologics, there are interleukin inhibitors. By all means, this list is not extensive, but there's IL-1 inhibitors. The classic one is anakinra. They'll use this for things like Still's disease. In fact, IL-1 inhibitors got also a use for people with inpatient gout. I said it, refractory to steroids, you could consider that. And then, of course, there's IL-6 inhibitors. The classic one is tocilizumab. I think COVID-19 put that on the map, didn't it? But definitely IL-6 inhibitors are now being used for things like giant cell arteritis. It actually got the FDA approval for polymyalgia rheumatica. So, and of course, we use this for rheumatoid arthritis. And maybe this is going to be a rheumatoid arthritis patient that failed TNF inhibitors, failed T-cell inhibitors, and they just wanted to try something that maybe an interleukin inhibitor. Then there's some really specific ones out there that get really specific indications. There are IL-17 inhibitors that got FDA approval for psoriatic arthritis and ankylosing spondylitis. There are IL-23 inhibitors specifically for psoriatic arthritis. And of course, usually we'll try a lot of these after you fail the classic biologic, which is a TNF inhibitor first. Last thing is other. There's something called repository corticotropin. It goes by the brand name Acthar. Acthar has two ways it works. A minor way that it works is that it represents a molecule very similar to the anterior pituitary peptide ACTH that will release endogenous glucocorticoid from the adrenals. But it also inhibits something called melanocortin. Melanocortin are receptors on the immune system. So Acthar, which is the name of the brand name of the medication, does act like a biologic. And it's FDA approved for diseases such as rheumatoid arthritis, dermatomyositis, and even we use it in people who have kidney disease like nephritis. And then if it's not going to be a biological DMARD, there's something called small molecules. Their claim to fame is that they're oral medications you can take by mouth, but they're just as potent in suppressing the immune system as a biologic itself, So treat them like biologics, rule out, latent tuberculosis, check Hep B, check Hep C. And the ones out there are going to be brand name is Xeljanz. That's tocilizumab, So there are three ones out there. And if you fail one, you may respond to another. But the key teaching point here, everyone, is that we do not combine biologics and small molecules together. We do not combine different categories of biologics together. You pick one, because you're really going to be suppressing the immune system quite a bit. So commonly, where the combinations we see is a non-biologic combined with a small molecule, or a non-biologic combined with one of these biologic in one of these categories. And it is confusing because many of these do have very specific indications, but at least I wanted to give you something to help organize your thought. And I really, really, truly hope this is helpful. I could spend an hour on this slide, but I do have some other things I want to cover. And I already could tell I'm kind of like, I need to pick up the pace. But hopefully this is going to be something that you guys enjoyed listening to.